Hello and welcome to the topic Type 1 Diabetes Mellitus in the Endocrinology module. By the end of this topic, you should be able to define Type 1 Diabetes Mellitus, outline the pathophysiology and causes of Type 1 Diabetes Mellitus, describe the clinical manifestations and list the differential diagnosis for this condition, outline the investigations done to diagnose and monitor the disease response to treatment, as well as discuss the management of type 1 DM and explain the complications of this type of diabetes. Let's get started. Type 1 diabetes mellitus, formerly known as juvenile diabetes, is a chronic autoimmune disease. The word diabetes was derived from the Greek word meaning siphon, to pass through, while mellitus is a Latin word meaning honeyed or sweet. The pancreas, which contains beta cells, produce insulin which moderates the glucose level in the blood. Owing to immune-mediated destruction of these cells, an individual goes through a state of absolute insulin deficiency and subsequently hyperglycemia. Type 1 diabetes mellitus results from an immune-mediated destruction of the beta cells. Adding on, the prevalence of type 1 diabetes is increased in patients with other autoimmune diseases such as Graves' disease, Hashimoto's thyroiditis, and Addison's disease. The pathophysiology begins with type 4 hypersensitivity autoimmune reaction, which attacks the pancreatic beta cells, eventually eliminating any insulin production by the beta cells. Destruction of the beta cells occur from months to years, resulting in hyperglycemic states once 90% of the beta cells have been destroyed. By then, patients would be diagnosed having diabetes mellitus. Although the causes are not fully understood, it is thought to be influenced by both genetic and environmental factors. Patients would complain of polydipsia, polyuria, unintentional loss of weight, lethargy, dry mouth, or blurring of vision. It is a challenge in identifying these symptoms in younger children as they are unable to communicate their thirst nor able to quantify to their toilet trips. Commonly, patients may complain symptoms of diabetic ketoacidosis, which is a common complication in type 1 DM, where their symptoms are nausea and vomiting, abdominal pain, drowsiness, or coma. In new cases of type 1 DM, patients may present with normal findings. Otherwise, patients might have orthostatic hypotension, signs of diabetic retinopathy on fundoscopy, absent or reduced in distal pulse volume, and low body mass index. In cases of diabetic ketoacidosis, patients may be in shock, dehydration, and loss of consciousness. Although the diagnosis is conspicuous, ruling out certain differentials are essential. Suggested differential diagnoses are type 2 diabetes, monogenic diabetes, secondary hyperglycemia, other endocrinal disorders, and drug-induced diabetes. With strongly suggestive history and physical examination, lab investigations are essential in diagnosing type 1 DM. In regards with that, either random plasma glucose, which has levels above 11 millimoles per liter, or fasting plasma glucose, where they have levels above 7 millimoles per liter, or plasma glucose levels post 2 hours 75 grams of oral glucose level above 11 millimoles per liter, or a HbA1c level above 6.5%. In symptomatic patients, a single positive result is enough to confirm the diagnosis. The management begins from the patient itself, where a continuous glucose monitoring plays a major role in it. Maintaining blood glucose at or very near the normal range is known to decrease the progression of microvascular disease in the affected young patients. Self-glucose monitoring is taught to all diabetic patients, and it is done using a glucometer. It is uncomplicated and user-friendly. It allows prompt actions to be taken for optimal treatment and prevention of hypo or hyperglycemia when it is performed at the correct timing as prescribed by doctors. Glucose monitoring should be performed 4 to 6 times a day and more frequent in certain conditions such as sick days or during exercise. It is a good practice to keep a diary to record glucose levels, insulin dosages, and dietary details for treatment adjustments. And it should be reviewed regularly by patients, families, and healthcare providers. As stated earlier, continuous glucose monitoring plays a vital role, so during every follow-up, a thorough history on any new symptoms with complete examination to assess the complications of the disease should be practiced. Patient education on the nature of the disease should be emphasized too. Random plasma glucose during every follow-up as well as HbA1c level every 3 months is obtained to monitor the control of the disease. Reviewing patients' personal diary on glucose levels and insulin therapy would be part of the follow-up as well. When it comes to insulin therapy, that remains as the mainstay therapy for type 1 diabetes mellitus. Multiple daily injection basal bolus insulin regimens are suggested as the regimen of choice for adults with type 1 diabetes. Few types of insulins are available, such as rapid-acting, short-acting, long-acting, premixed, and intermediate-acting insulin. Commonly, insulin pump will be provided together with education of the usage technique to the patient. Hypoglycemia is a common complication of insulin therapy. Identifying and managing it as soon as possible is essential. So step 1, if there's hypoglycemia, administer intramuscular glucagon by a family member or friend who has been shown to how to use it. Intravenous glucose may be used by healthcare professionals skilled with getting intravenous access. Step 2, check for response at 10 minutes. And step 3, and then give intravenous glucose if their level of consciousness is not improving significantly. Step 4, provide them with oral carbohydrate when it's safe to administer it. And step 5, put under continued observation by anyone who has been warned about the risk of relapse. This is important to also identify the classifications or the severity of hypoglycemia. If the patient has mild hypoglycemia, then oral carbohydrates are sufficient. On the other hand, diabetic ketoacidosis, which is a state of hyperglycemia and also a common complication of type 1 diabetics, should be identified and managed appropriately. As soon as possible, they should visit the hospital. They should be provided isotonic fluid replacement, electrolyte monitoring and replacement, identifying and treating the precipitating factors, as well as administration of insulin by infusion. As mentioned earlier, the complications include diabetic ketoacidosis. We have vascular complications, which can be major, such as peripheral vascular disease, cardiovascular disease, and cerebrovascular disease, as well as minor, such as peripheral neuropathy, retinopathy, and nephropathy. Other than that, infections can be also the complications of poorly controlled diabetes and hypoglycemia. So in summary, type 1 diabetes mellitus is a chronic autoimmune disease causing immune-mediated destruction of the beta cells, resulting in a state of absolute insulin deficiency and subsequently hyperglycemia. It is caused by genetic and environmental factors, where patient presents with polyuria, polydipsia, unintentional weight loss, dehydration, and signs of shock. There are few differentials to be considered, such as type 2 diabetes, monogenic diabetes, and secondary hyperglycemia. Diagnosis is confirmed by either random fasting or 2-hour postprandial plasma glucose or HbA1c levels. Maintaining blood glucose at or very near the normal range is known to decrease the progression of microvascular diseases in the affected young patients. Insulin therapy remains as the mainstay therapy of type 1 diabetes. Identifying and managing hypo or hyperglycemia is vital in the principles of management of type 1 diabetes, and all patients must be reviewed in order to identify the complications early and manage it. We have come to the end of this topic. Thank you.